Hi students, good morning and welcome to sessions in oral pathology. I am Dr. Gopi Krishnan here to discuss oral pathology with you. Okay, I know that you guys are having problem with oral pathology. It's a very volatile subject. You may feel that oral pathology is a very vast and volatile subject. There is a lot of things to learn by heart and all for your NEET INACD examinations. And most of the students, they have doubt what to study, from where we should study oral pathology. Do we have to read the old Schaeffer's or the old Neville? Okay, and that is quite impossible when you are preparing for the exam in a very short period of time. Okay, you have a long syllabus in other subjects also, and how can you read a textbook completely during your preparation time? Okay, so we are here to help you. Okay, we are here to help you. There is no big stuff in this. Okay, it is very easy if you are understanding and studying oral pathology. Okay, you know that oral pathology is a non-clinical subject. Actually, I say that it is a clinical subject because these things, what you learn in oral pathology, is what you see in your clinics. A patient will always come with such a pathology into your clinic, and he will present all the clinical features to you. Okay, the diagnosis part is just a piece of slide which you take the biopsy from. Okay, so usually the pathology, I say that they are clinical. You have to learn it in a clinical way. You have to imagine the patient, you have to visualize the patient, visualize the condition that the patient is suffering, and it will be very easy for you then. Okay, it is interesting then. Okay, and it's not always this pink and blue stuff. And I'm here, we will discuss oral pathology. We will see the major topics, what I say, the focus areas. Okay, the focus areas where this INICT and the NEET people pick questions from, and how they puzzle you, what you want to know. Okay, how can you tackle them? Okay, so this is what we are going to discuss in our sessions. Okay, so kindly pay attention, kindly see the videos, and I will discuss with you all the tips and tricks where they will pursue you, what they want, what they expect from you. Okay, so we will see the focus areas, and to begin with, we'll start with certain syndromes. You know that there is n number of syndromes in your syllabus, and how can you memorize all these symptoms? Okay, or you can't memorize all these syndromes, but I say that if you visualize the patient with the syndrome, it will be very easy. Okay, you have to visualize a patient with that syndrome, and we will see major important syndromes in this session. So let's start with the first syndrome, that is your Parry-Romberg syndrome. So you are seeing this picture here. Oh, there's a child, very beautiful child here. Okay, and what can you see in this picture? Parry-Romberg syndrome. So you see this girl here. Okay, and from the picture itself, you can see that the one side of the face of this child. Okay, can you see the right side of this child? The right side of the child is little lesser in content than the left side. So we have the right side here, we have the left side there. The right side of this child is having a lesser thickness or lesser content than the right side, so than the left side. So you can now imagine, you can now understand what condition is she is suffering from. Parry-Romberg syndrome means it is a reduction or atrophy. It's an atrophy in the one side of face. Okay, so atrophy is happening on one side of the face, so it is hemifacial. Hemi, that is half side of the face. It is called a hemifacial atrophy. So hemifacial atrophy is a condition what you see in Parry-Romberg syndrome. Now it is very easy. Now all the clinical features are easy for you once you know the what the problem is. So the hemifacial atrophy. What happens when there is hemifacial atrophy? What it means the structures on one side of the face are reduced than the other side. Means what are the structures? Your fat, your muscles, your nerves, or any of the structures, your bone. Okay, in one side of the face has reduced. So what you see the features, what are the features you see here? You can see that it mainly comes in younger individuals. Okay, in younger individuals it start observing, and you can see that usually it is seen in less than 20 years of age. And what are the other features you see? You see this, there is a reduction. I say reduction in the subcutaneous fat. Cutaneous fat, mainly the fat adipose tissue in that area is affected. The fat is reduced. Okay, the bone tissue is reduced. There is a reduction in the bone density there. So we can see, what we can see, that is hypoplasia. bone hypoplasia in that side, your maxilla, your mandible. You can see the the major bones there is the maxilla and the mandible. Maxilla and the mandible is what, getting hypoplased. Okay, so this is the one thing you see. And other things you can see is that there is pigmentation, some pigmentations in the skin in that area. And there's one interesting thing what you can see in this perirhombic syndrome is that there is a line of demarcation. A line demarcates this what, atrophied side from the non-atrophied side. And that line of demarcation is called Coupe de Sabre. Coupe de Sabre, it literally means that a cut with a saber, or a saber's cut. Okay, so that a line demarcates between your atrophied and non-atrophied side. Okay, and this Coupe de Sabre, it is seen in one other condition also, that is called scleroderma. Scleroderma is another condition where you can see this Coupe de Sabre. Okay, so this is not only in perirhombic, in scleroderma also. Now, what was the question? There was one question asked in your NEET INICET examination. NEET examination, it was about Parry-Robert syndrome. Which of the following condition or which of the following feature is not seen in your Parry-Romber? But you don't have to by heart that. Okay, a common sense. If a aspirant is using his common sense, he could have easily answered that. Okay, so their question was, what about the eyes? What about the condition of the eye on the affected side? Okay, so you know that there is a reduction in the fat, and our eyeballs are placed in the socket with a periorbital fat. Okay, periorbital fat. Periorbital fat means the fat is lining the eyes. Periorbital fat hold the eyes. Okay, so there is a reduction in the fat in that area. There is a reduction in the periorbital fat. What happens when the orbital fat is reduced? Your eye will be sunken inside. It will go inside. So what happens? There is a reduction in the periorbital fat. It will lead to a sunken eye. So you call it ophthalmos. Ophthalmos. Ophthalmos means the eyes are going inward. So the question was, following feature is not seen in Parry-Romber syndrome. The option was exophthalmos. Okay, it is not the outward protrusion of the eye. It was the inward sunken eyes, or inward movement of the eyes because of the loss of periorbital fat. It is mere common sense. We know that it is atrophy on that side. So the eyes will go inside. And what are the other things you see? You can see trigeminal neuralgia. Okay, you can see trigeminal neuralgias in these conditions. And what else you can see? You can see epilepsy because of the defective nerves in that side. You can see epileptic conditions, trigeminal neuralgia in this condition. And what about the oral cavity? What is the thing affecting the oral cavity? The mandible and the maxillary bone is affected. Okay, what happens? There is a problem with the eruption. There is a delayed eruption of the eruption of the tooth. Sometimes the tongue on one side is atrophied. Okay, you can see there is an atrophy of tongue in one side. Okay, and these are the certain features you see in your Parry-Romber syndrome. Now I think the Parry-Romber syndrome is very clear to you. Such a simple thing. Okay, such a simple thing, you always remember about the atrophy. So shall we move to the next syndrome? Okay, next syndrome. Yes, you can see this person. Okay, that syndrome, that is Treacher-Collins syndrome. Treacher-Collins syndrome. You see, you observe the patient's face for some time. You can see that his face, you can see his eyes, its lower eyelid, it is little saggy down. See about his jaw, the jawline, and also see about the bridge of the nose. Okay, you can see that person. You just observe the person here. So the other name of Treacher-Collins syndrome, it is called mandibulofacial dysostosis. Mandibulofacial dysostosis. Mandibulofacial dysostosis. What does mean by dysostosis? Dysostosis, what is the meaning of dysostosis? Dysostosis means a abnormal development of bone. Okay, there's meaning for everything. In oral pathology, you should know the exact meaning what the term denotes. Okay, then half of the problem is solved. Okay, don't by heart, don't mug up. Dysostosis means an abnormal development. Okay, abnormal development of bone. So mandibulofacial, mandible and the face. Your mandible and the face, the bone in the mandible and bone in the face are abnormally developed. Very simple. Okay, so Treacher-Collins syndrome is mandibulofacial dysostosis. So you know that the mandible and the face is having problem in the development. And what's the reason for this? The reason for this mandibulofacial dysostosis, it is a defect of a gene actually, a gene mutation. And guys, I say that if you are an aspirant for INICET, if you are wishing to be in the AIMS or PGI exams, if you are aiming for such exams, okay, I say that you should be thorough with the molecular aspect. Okay, the molecular aspect, the gene mutations in most of the tumors. You can make a chart as the syllabus goes. You can make a list of most of all gene mutations, which gene is mutated, because INICET exam question papers, if you work out previous year question papers, you can see that they really ask this gene mutations. Okay, which gene mutation is seen in pleomorphic adenoma, which gene mutation is seen in Treacher-Collins syndrome. Okay, all these gene mutations, you can list it out. The gene mutation which you see in Treacher-Collins syndrome is a gene that is TCOF. Okay, Treacher-Collins TCOF. Okay, 1. Okay, TCOF1, just remember the TCOF1. There is one more gene which is mutated, that is POLR1B. It is not that important, you just remember TCOF1 at least. Okay, and it is a autosomal dominant type of inheritance. Okay, it is an autosomal dominant, AD, autosomal dominant type of inheritance. So this is the basic thing about your Treacher-Collins syndrome. And what are the features you see? If I talk about the features in Treacher-Collins syndrome. So I told you that there is a defect in the mandible as well as your face. That is clear for you. Now, what is the main thing? You see this picture? What is lacking in that person? You can see the mid face of this person. Okay, you can see the mid face of this person. There is no cheek prominence. Okay, see the cheek prominence is gone. Okay, so there is a hypoplastic malar prominence. Okay, so that the malar bones are hypoplastic here. Okay, I say hypoplastic. Malar bones are the one giving your that prominence of your face, right? Your beauty lies in the malar bone, right? That will be hypoplastic, so you will feel that area empty. Okay, and what happens next? When there is a hypoplastic malar bone, and then mandibular hypoplasia. Okay, so your bones in the face and the mandible. Okay, so this is what it explained: mandible and the face. Face prominence is given by your malar bone. Your mandible, you see this picture, the mandible of the person. See this. Okay, that prominence of the mandible is gone, right? So this is what you see here. Okay, so there is a hypoplastic malar bone, there is mandibular hypoplasia. So whenever there is a mandibular hypoplasia and the malar bone is not there, you can see that the mouth is small here. The person's mouth, that condition is called a micrognathia. Okay, micrognathia, the jaw is small. Okay, jaw is small. And what happens when the jaw is small? Can just imagine, just use your common sense, connect one with another. Okay, the malar bone is less, there is a hypoplastic mandible, your oral cavity is less, and the mandibular bone is put backward. So you know that the tongue is attached to your mandibular bone. Okay, the tongue is attached to your mandibular bone. The mandibular bone is put backward. What happens in the posterior region? The airway which will be getting narrowed. Okay, so what happens in usually in children? What happens is that as there is micrognathia, as there is a defect in the malar bone, as the oral cavity is less, the pharyngeal region will get pushed backward. So the tongue is pushed backward due to this micrognathia. The person will have sleep apneas. Okay, apnea. Why there is sleep apnea? Sleep apnea is because of the the reduction in the size, in the airway in the pharyngeal region, because your mandible is pushing backward, the tongue is kept backward, right? There is sleep apnea. And why? Because this is due to narrowing of the trachea, narrowing of your trachea. Trachea and the pharynx is get narrowed. So this is what happened. This is what happened in a Treacher-Collins syndrome. So now you understood what happens in a Treacher-Collins syndrome, right? Now, what else? The facial feature you see. The facial feature you can see. You can see this. I see his eyes. Okay, see his eyes. You can see that it is coming downward. Right, so there is a downward slant. There's a downward slanting of the eyes. So I write the other features. Other features are downward slanting of eyelids. The eyelids are slanting downward, and you can see that you could clearly see that the lower eyelid has a depression, right? See, see the depression in this lower eyelid. Okay, you can see that it is there is a depression in that, and that is called a colobomas. Coloboma. Okay, coloboma, the outward portion of the lower eyelid has a depression. Okay, that is colobomas. Okay, now what else the defect I can add on to this is that there's a defect with your pinna, the ear pinna defects. Okay, the external auditory canal and the pinna. Okay, there's a defect with the ossicles. Ossicles will be having defect. So you know that when the ossicles, your ear ossicles are defective, the person will have hearing loss. Okay, the person will suffer from conducting hearing loss. Okay, and sometimes rarely this person will have clefting also. Cleft palate can be seen in this persons. So this is all about your tetracolon. So tetracolon, just remember mandibulofacial dysostosis. Simple, mandible and the face. So your mandible is hypoplastic, your malar bone is hypoplastic. Okay, so this will result in a smaller opening or a smaller oral cavity. The mandible will be set back, your tongue will fold back, the pharynx and the larynx trachea area, the airway area is reduced, and there you can see what they can see there. The child will be suffering from sleep apnea. On the face, you can see there's a downward slanting of the eyes, the colobomas, ear ossicle defect, conductive hearing loss, and even the cleft palate. So how simple is this? Okay, so this is, we have learned two syndromes. Okay, now let's see the next syndrome. Okay, we have Curson syndrome. Yeah, we have the Curson syndrome here. Okay, can you see this person? Can you see the picture of this person? Okay, and there are so many things we have to learn in Curson syndrome, and Curson syndrome is very interesting. Okay, see this person. Okay, Curson syndrome, the other name for Curson syndrome is craniofacial dysostosis. Okay, craniofacial dysostosis. So again cranium face dysostosis. Okay, split and learn. So cranium, have cranium. You know what about the cranium? Cranium is your skull, right? What we call cranium is your skull cap, right? Cranium, that is your head, and your skull region has some defect. Facial, craniofacial means there is face, and again dysostosis, abnormal. So we have discussed what is dysostosis, abnormal development of bone. So here the defect is between your face and your cranium. Okay. Okay, the tetracolon was mandibulofacial dysostosis. Here, Curson, start with C. So C again, cranium. C for C. Curson for C. Cranium for C. Craniofacial dysostosis. Simple as that. So what are the features? What's the thing you see here? First, we will see why this is happening. Reason. What is the reason for this craniofacial dysostosis? There is a gene called FGFR2. FGFR2. Please remember this gene if you are preparing for your INICETs. INICET, they are very famous for asking genetic or molecular based questions. Okay, FGFR2 is a gene which is responsible for the development of your cartilage and your bone. Okay, where normal bony development FGFR genes are required. That is fibroblast growth factor receptor gene. Okay, so that is very much important. Any defect, any mutation in this FGFR gene, we have a syndrome called Curson syndrome. In the end of this session, I will give you a table which I have prepared for you from different textbooks. Okay, in that I have tabularized most of the syndromes and its features and the genes. Okay, I will give you that table to you that I have prepared for you guys. Okay, you can have it for a quick reference also. Okay, so here what happens, it is also a autosomal dominant inheritance. Okay, it is having an autosomal dominant inheritance pattern, just like your mandibulofacial dysostosis, right? So what happens in your cranium? What is really happening? So we are concerned about the cranium here. So cranium, in the cranium, you know that there is so much of sutures. Your coronal suture, your sagittal suture, sutures are there. Sutures are there in the cranium. The defect is with the sutures. Now these sutures, actually it is not closed very early. Okay, it gives space for your brain cavity to expand. Okay, your cranial cavity to expand. The sutures are closed at the right time. It will get closed at the right time when the brain development is occurred. Okay, but in this person, what happens? There's a premature closure. The premature closure of the brain sutures or your cranial sutures. So what happens is that the premature closure, so what happens, there will be intracranial pressure. The cranium will be having a altered shape because you know that your suture coronal, your coronal suture, your sagittal suture, okay, your lambdoid suture, mostly your coronal and sagittal sutures are affected here. Okay, so these two sutures are usually affected and they get fused or prematurely fused. So what happens, the cranium cannot be grown completely. So what are the clinical features you see in such patients? Okay, what are the clinical features when your coronal and sagittal sutures are prematurely closed? What happens? And you have an altered shape of your cranium. Okay, there's a defect in shape. Sometimes it is small in shape, that we call brachycephaly. Brachycephaly means the sutures are closed prematurely so that the cranial cavity is not expanding. It is small, brachycephaly. Or sometimes it will be scaphocephaly. Scaphocephaly means it will look like a boat shape or a different shape it will take. Sometimes it is looking like a triangle. It is called a trigonocephaly. Trigon, trigonal, trigonocephaly. Okay, and sometimes all the sutures will be closed, and what happens, your skull will feel like a clover leaf. Okay, so clover, have you seen a clover leaf? You may have seen it in cards which you play clover. Okay, you have seen a clovers like this, like clover structure like this. So it is called a clover leaves like structure, clover leaf skull. It is called a cleaved star, cleaved shuttle. Okay, cleaved shuttle shaped skull. Cleaved shuttle shaped skull means clover leaf shaped skull. Okay, this is because of the fusion of all the sutures together. Okay, it will give a shape to the skull. It will look like a clover leaf. Okay, so this is called these are the features you see in the what cranium. Now use your common sense. I want you to use your common sense. What happens when these cranial sutures are fused prematurely? You have no space to expand. Your brain has no space to accommodate all the structures. What about your orbits? Okay, what will happen to your eyes? Now here, there's no space for the eyes to sit, right? The skull is not expanding. Okay, so eyes, there is no space for the eyes to split. So what happens? The eyes will pop out. So in Parry-Romber syndrome, the fat in that eye region is lost and eye was going inside. So here what happens, the skull is fused prematurely and the bone is fused and there is no proper placement of your eye. The eyes will pop out. So what condition you see in this syndrome? Okay, what condition you see in Curzon syndrome? It is exophthalmos, eye coming out. It's called a exophthalmos, the condition where you see exophthalmos. So once you know what is really happening, you can easily say the clinical features. There is no need to by heart. Students taking up this Curzon syndrome by hearting it. Oh, it has exophthalmos. Okay, but in the exam, when you see the other options, you will get puzzled up. Okay, but a aspirant, a student who's understanding, yeah, what is really happening there? What is the defect there? Okay, so and so the skull is not fused. So fused, the skull is already fused, and there's no place for the eyes to sit. So definitely, it will come out. It will pop out. That is exophthalmos, or we say proptosis. There is proptosis. So what happens when the eyes is always bulging out? Okay, imagine that person. You see this person. You see the image. Can you see the eyes are coming out? Eyes is popping out. You can see that the eyes is popping out, right? His conjunctiva cannot close it completely. The eyes are popping out. So when the conjunctiva is not completely closing the eyes, you know that how long you can open your eyes and see it. It will cause dryness in your eyes. It will cause conjunctivitis. It can cause blindness. Okay, so simple. one is related to the next. There is proptosis, there is conjunctivitis, and repeated conjunctivitis, repeated irritation to the eye, that can cause a blindness. Okay, blindness. Same thing, you can see what happens to your ears. Okay, as the bone is fused, and there is no proper development of your internal ear. There is no proper development of your internal ear. The ear is not properly developed. Your malleus incus stapes, the muscles, sorry, the bone inside the ears, they are not properly developed. The person will have hearing loss also. There will be increased pressure, increased I will write increased intracranial pressure, because the brain is developing, and what happens, there's no space for this brain to sit inside the cranium. What happens, the brain will push onto this skull. Okay, the brain tissue will push onto this skull, and it will make some indentations on it. Okay, it will make some markings on it. Okay, so there is an increased intracranial pressure, and what happens is that the brain tissue will make some imprints on it, imprints on the skull, and it is like a imprints on a metal. Okay, when you take a hammer, you take a metal sheet, and beat it. Okay, you beat the metal, but you can see that you can see the indentation of the hammer being produced on the metal. Just like that, there will be imprints on the skull. It is called a beaten metal skull, the beaten metal pattern. Okay, beaten metal pattern, you can see. I can show you the image also. See this image. Oh, see this radiograph. I think it is very clear to you. And can you see this is indentation? There is 1 2 3. Okay, can you, if you observe properly, you can see that there is small indentations on the skull. Okay, just like a hammer is being used to beat a metal. So this presentation is called a beaten metal pattern, right? So I hope the image is clear. Beaten metal pattern. What else you can see? You can see that it is a craniofacial. So we have discussed about the cranium and the face. And one thing you should remember, even if the brain tissue has no space to develop, the patient's intelligence is good. Okay, so there's no defect in intelligence. Okay, the problem is not with their brain, the problem is with their sutures actually. Okay, so the person will have an intelligence, which is a good IQ, it will be there. Okay, now what else? We have seen all the defects in the cranium. Now we'll see the face. What about the face? The other thing you see on the face, you can see mid face hypoplasia. Yeah, mid face cranium and the face is the defective. So face, what the malar prominence is gone, there is mid face hypoplasia. So there is a hypoplastic maxilla. Hypoplastic maxilla is seen. Okay, but no problem with your mandible. Here there is no problem with your mandible, only the mid face, the cranium and the face. It is not mandibulofacial. Okay, it's not mandibulofacial, it is craniofacial. So your maxilla and the cranium. The cranium defect we have seen about the sutures. About the face, mid face hypoplasia, malar prominence gone, hypoplastic maxilla. So what happens? You have a class 3. Okay, the occlusion is class 3. The maxilla is going inward, mandible will look that it is coming forward. Okay, it is not a true class 3, but it will look like a class 3. Okay, so we say relative mandibular prognathism. It is not a true mandibular prognathism, it is a relative mandibular prognathism, because maxilla is going inward. So we can get a relative mandibular prognathism. Okay, so this is how you learn. This is how you relate, and you relate one thing with the next, and it is very easy. So this is what happens. And sometimes you can see cleft palate also. A cleft palate or cleft lips are seen, but it is not as frequent as the other syndromes. Okay, so this is about your what Curzon syndrome. So we have discussed 3 major syndromes, right? Curzon syndrome, and one another is your Apert syndrome. Yeah. We'll move to the next, and we'll see what is there in the Apert syndrome. Okay, so see the person here. I hope you can see all the images here. Right, okay, this condition is called your Apert syndrome. So Apert syndrome is just like your Cushing's itself. Okay, just like your Cushing, there is a syndrome called Apert syndrome. And if you know the other name of this Apert syndrome, what was the name for the Cushing syndrome? It was craniofacial dysostosis. So what is the name of the syndromes that come in Aperts? It is called the ACS. I will explain this. One, if you know ACS, there's no need to buy heart. Okay, so what is ACS? Acrocephalosyndactyly. Acrocephalosyndactyly. Have you heard about this term, acrocephalosyndactyly? So this is the issue. Okay, this is the problem. We don't learn what exactly it is. We just by heart. Okay, that is the issue with your exams. That's why you find this difficult. Once you understand what really happens there is no need to by heart it. You will be masters in this. Okay, you will be masters in syndromes. You will not miss any question in syndrome while other students find it difficult, right? So this is a scoring area. Pathology is dry. Pathology is volatile. It is volatile for every students. We are gonna write a competitive examination. If you're good in endo, you may be good in clinical subject, you may be good in prosto. Every student are like that. They are also having interest in clinical subject. They are also having upper hand in endo. They are having upper hand in surgical subjects, and it's interesting for all. And students find this non-clinical subject as very volatile, and they usually skip this. But this is a scoring thing. Out of 240 questions in oral pathology, you can get 40 questions. 240 questions in your NEET, you can get 40 questions from your oral pathology, oral medicine, oral radiology area. That is the area where all the students find it very difficult and very volatile and very boring. Right. So how you have to learn is understand acrocephalosyndactyly. Acro means your cranium. Acro is cranium. Cephalic region, that is your face and cranial region. Okay, face and the cranium, this part. Okay, acrocephalosyndactyly. Dactyly is your digits. Syn means a fusion. Syn, sync. Okay, means fusion. So cranium, there is a defect with your cranium, there is a defect with your face, there is a defect with your digits, where the digits get fused. Okay, so Apert. Okay, Apert syndrome में क्या है? Apert, what's there in the Apert syndrome? Acrocephalosyndactyly, cranium face fusion of your digits. Okay, so what exactly happens here? Before that, we will see what is the reason for this. Again, the reason for this, it is very similar to your Cushing syndrome. It is very similar to your Cushing syndrome. We have learned Cushing syndrome. This is also due to FGFR2 gene. FGFR2 gene mutation, and it is also autosomal dominant inheritance. It's all the same. So I say that this is actually a Cushing with a fused digit. Okay, it's actually what happens here. It is a Cushing syndrome. It's a Cushing syndrome with a fused digit. Okay, this is what happening in your Apert syndrome. So if you mix Cushing syndrome with a fused digit, you get Apert syndrome, just like a recipe. Okay, you're making a recipe. You may have seen recipes of cooking, right? You mix Cushing syndrome with put some fused digits, and you get Apert syndrome. Very simple. Okay, now what are the clinical features? What are the clinical features you see here? Same, craniosynostosis. Okay, you are seeing craniosynostosis, just like your Cushing syndrome. And same time, you can see the exophthalmos. All the features you see in the Cushing syndrome, you can apply it here also. What about the eyelid? It will be the downward slanting of the eyelid and all. Okay, all this you can see. You can put hypoplastic maxilla. You can see Okay, relative mandibular prognathism, everything. I'm not going back to Cousins again. Okay, all the things you can see. What is the other thing you can see is that the extra thing here is the digit. The problem with the digit means your fingers, and what happens here, the digit will be fused digits is what you see. Fused digits on what mostly your second, third and fourth digits. Okay, your second, third and fourth, this middle things. Okay, this will be fused together. This is what happening here. Second, third and fourth digits, you see the image here. Okay, see this picture, you can see that the digits are all fused together, and you can see the thumb is broad. Here we have, see the thumb is broad and the digits are fused here. Okay, you can see that from the picture. So this is what extra thing happening here. Okay, all the digits are fused, there will be broad thumb. Now, what extra thing you have to remember here is that the Curson syndrome, in Curson syndrome, there was no defect in the intelligence. But here, what happens? There is a defect in intelligence. Please remember this. Okay, defect in intelligence, that is IQ of the person is reduced. So this was once asked in your NEET examination, which upon the following statement is true regarding Upper syndrome. Okay, so which among the following, so those questions, we say it apply supply questions. Okay, apply the knowledge, supply your answer, you get the mark. So that is apply supply questions. Okay, so there is no big science in this. If you know the concept, you have the score. Okay, if you don't know the concept, you will make some guessings and you will get it wrong. Okay, so just use this thing, Curson versus Upward. Curson and Upward, you have to learn it together. Okay, so it is very easy. In Curson's, there was no problem with your IQ of the person was fine, but in Upward the IQ is reduced. Rest all the things of Curson's, you can see the beaten metal pattern. Okay, here also you can see the beaten metal pattern and your clefting. Okay, cleft palate, all these things you can see. Okay, so hope you are clear with this Curson syndrome, Upward syndrome, and your Parry-Romberg syndrome. So these syndromes we have done. Now let's see in the next part. We will discuss few more syndromes in the next part of the video. Thank you.